Welcome back to Catalyst University. My name is Kevin Tokoph, and in this video we're going to talk about an under-discussed condition that from time to time will present itself in the physical therapy clinic, and that is a condition called athletic pubalgia, also known as sports hernia. Those two things are one and the same. In this video, we're going to talk about how to examine it and identify it properly, and then also what are the best practices for treating this condition in the PT clinic with exercise. So the first thing we need to talk about is what is athletic pubalgia? Well, athletic pubalgia is a condition that is also known as a sports hernia. Athletic pubalgia equals sports hernia. Two different terms, the exact same condition. And while one of those terms has the name hernia in it, this is not a true hernia. When we talk about hernia, that implies a herniation, meaning there's a tear in the abdominal wall, and now, under certain circumstances, you have contents of the abdomen and or pelvic cavities that are trying to protrude through that hole in the wall. And oftentimes what you see, and we'll talk about this a little later on, is let's say you have an umbilical hernia, you put your fingers firmly in there, cough, and you'll actually feel some palpable protrusion of contents through that hole in the abdominal wall. A sports hernia is not a hernia in that sense. There's no actual hole in the abdominal wall through which contents might try to go through. That doesn't mean, though, that there's not weakening of the abdominal wall in a specific area or that there's a small tear, but there's no actual specific herniation, if that makes sense. Weakening or a small tear. Now, normally, if this is a chronic issue, there may have been an initial tear and it's progressively getting worse and it's weakening the wall in that area, or it could just be a progressive weakening without a tear. Or this can present acutely. Somebody does something, strains a little too hard, and there's a little tear in the abdominal wall. So it can present acutely, it can present as a chronic issue, but there's no actual herniation. This image on the right was taken from this study, Resisted Adduction Sit-Up Test as a Screening Tool for Pelvic versus Hip Pathology. Now in the image, kind of in the center of all those arrows, you see the pubic aponeurotic complex. So it's a bundle of connective tissue, and attaching to that are various structures like muscles and fascia associated with other muscles. Arrow number 1 represents the rectus abdominis muscle. Arrow number 2 is the transversalis fascia, and several of the other core muscles attach on the transversalis fascia, which then in turn attaches at the pubic aponeurotic complex. Arrow number 3 is the inguinal ligament. Arrow number 4 is the pectineus, and arrow number 5 is the adductor longus. And so because there's multiple core muscles and multiple adductor muscles that all attach at this pubic aponeurotic complex where a potential tear occurs, this explains why resisted abdominal movements and or resisted adduction movements can aggravate pain associated with athletic pubalgia. And we'll actually use this information to our advantage when we get to the testing for this condition. Now, how does a sports hernia present? Well, it often presents with anterior hip pain on the affected side. And usually when we have anterior hip pain, that presents as a C sign pattern. So you make a letter C with your first web space and you stick it right over the front of that hip, fits nicely over there. That is a C sign pattern of pain. And when we see that C sign, we're quick to assume this is a hip joint issue. Maybe it's the labrum, maybe it's impingement, maybe it's a ligamentum teres issue, whatever it is. But it may actually not be that if we delve deep enough and specific enough in the objective exam. So often presents as a hip joint issue. Now there's not one thing that causes a sports hernia, but oftentimes it can be caused by overuse and repetitive motions, particularly those that involve a huge demand on the core and core stability. I had a patient recently that I diagnosed as having a sports hernia, and his mechanism of injury was he was on the job, and along with the help of a few other guys, they have to hoist overhead some very large, heavy wooden beams. And not only are they having to hold it, but they all receive that beam very rapidly, very suddenly. They have to brace in order to catch it and hold it. And when you're doing things with your arms up overhead, there's a greater demand on the core. We all know with squats, let's say, that if you do a standard back squat with your barbell here, yes, there's some core work there, But if you hold the bar up overhead, that dramatically increases the demand on your core. The higher your arms go up, the more core demand you have. And especially when you're doing this repetitively on the job, it's overhead. There's some perturbations involved with that. The fact that there's some quick movements, you got to be able to adjust real quick, catch it, right? It's a reasonable mechanism for developing a sports hernia. Also, if you are doing core work or other exercises that involve heavy core use, and you're not adequately warmed up, or maybe your core is your weak point, you're more likely to develop a sports hernia. So if you are not used to doing core work and you go in and immediately try a GHD rotational sit-up, you may not be prepared for that. That could very well cause some injury, and maybe it's a sports hernia. There's also no visible or inducible bulge through the abdominal wall that we would typically see in an inguinal or an umbilical hernia. Like I said, there's no actual protrusion of abdominal contents through a hole in the abdominal wall because there is no hole. It's not a true hernia. So hopefully at this point, you understand what athletic pubalgia is. Now we need to understand how to assess for it. Now on this slide of the next few, I've got a few things labeled 1, 2, 3, 4. I don't want you to think of these as cookie cutter steps that you have to do in the same order in order to accurately diagnose the problem. These are just my recommended things, the bare minimum things that you would need to do to confidently rule in a sports hernia. Now, of course, I'm going to do other strength measurements. I'm going to do other mobility measurements, but this is the bare minimum to be confident with that diagnosis in the end. And one of the things you need to do, the first thing we'll talk about, is you need to rule out the hip joint. As we'll see later on in the video, hip joint issues present very different than abdominal and pelvic issues. Those are two different things. A sports hernia is an abdominal pelvic issue. It is not a hip joint issue. So we need to do some hip joint tests and make sure that these are negative and not reproducing their familiar pain in order to rule out the hip joint. And I have these tests here ordered at the top, lowest vigor down to highest vigor. The order of testing in terms of vigor becomes really important when you have a very severe, very irritable patient in front of you. If they're very low on those, on your SINs, doesn't really matter as much. But if they've got a lot of resting pain and you know the pain can go up pretty high, maybe it stays that way a long time, you definitely need to consider the order of these tests. Okay? And the first two that I would do, absolutely non-negotiables, are hip flexion and internal rotation passive range of motion. Yes, I'm assessing for the actual range of motion. Is it limited? Are we encountering a firm or hard end feel, right? What's the end feel, right? But I'm also assessing for a pain response. Does it provoke their familiar pain? If it doesn't provoke their familiar pain, then I move on to the next one. And the next one would be the Fadier test, flexion adduction internal rotation test. This is one of the non-specific hip joint tests. If this reproduces their familiar hip pain, it's very likely to be a hip joint issue. It doesn't tell us what the issue is. It could be simple capsular stiffness. It could be a ligamentum teres rupture. It could be impingement, labral tear, anything in between. It's not specific, but it's a highly sensitive test. If it's negative, it's not a hip joint issue. And then if Fadier test is negative, we'll move on to the hip scour test, which is a little bit more aggressive. We've talked about Fadier and scour in other videos. I'll be putting links to the demonstrations of those in the comments section of this video. But essentially, if these tests are negative, they don't reproduce the patient's familiar pain, well, then you have effectively ruled out the hip joint and you can move on in your examination. Now, palpation. Palpation is really important for diagnosing a sports hernia because normally the pain is in a fairly specific spot. So usually what I do first is I begin laterally at the rectus femoris proximal tendon, which is underneath or inferior to the AIIS. Okay. You can also have the patient extend their knee actively and feel the muscular part of that muscle, trace it up to the tendon if you're having trouble finding it. But you want to make sure that the pain is not on the rectus femoris tendon. You could also consider doing a seated and or reclined quadricep manual muscle test while you're palpating that tendon, just to really rule out that tendon as a source of the pain. If that's not their pain site, move on. And I would move on medially to the iliopsoas conjoint tendon. The iliopsoas tendon is medial to the rectus femoris tendon. And what you can do is you can have the patient sitting and essentially hike their hip up with the knee bent. And you should be able to feel that tendon activate pretty strongly, feel it tense, okay? If that's not the major site of their pain, especially if you have them do this and even add a little resistance, right? And that's not the site of their pain, move on. And I would move even more immediately. And if you find that their pain is maybe about 1/2 inch medial to the iliopsoas tendon, that is roughly where most sports hernias present. And you're getting into this area where you're kind of around the inferior abdominal wall, and that's where that weakness occurs and or those small tears, okay? So if you're in that vicinity, it's very likely to be a sports hernia, assuming you've ruled out the hip, but also assuming you've ruled out a true hernia, right? Because some true hernias can actually occur in that spot. So we want to rule out an inguinal hernia and an umbilical hernia. What you do for those, it's actually fairly simple. You find the umbilicus, get a firm pressure on that, and you have the patient cough. If there is a large bulge that protrudes into your fingers, that would be positive for a true hernia, an umbilical hernia. Then what I would do is I would go to the affected side in the inguinal area. Again, 2 fingers in there, cough. If there's a very large bulge into your fingers there that's larger than on the unaffected side, so test the other side too, that would be positive for an inguinal hernia. If you think that the person has a true hernia, that is an umbilical or inguinal hernia, it is not a sports hernia. And you probably should have the person follow up with their physician to determine exactly what should be done next, because in some cases those may require a surgical operation. But if those are negative for that protrusion of the abdominal contents out, then you've essentially ruled out a true hernia. Because remember, sports hernias should not cause a bulge through the abdominal wall because there's actually not a physical hole there to protrude through. Hopefully I've beaten that horse to death. Now at this point in the examination, you've got a lot of valuable information. You've ruled down a hip joint pathology, ruled down a proximal rectus femoris tendinopathy, ruled down an iliopsoas tendinopathy. You've ruled down a true hernia, such as an umbilical or an inguinal hernia. And you know the pain location. It's usually going to be medial to the iliopsoas tendon. And you need to now do some resisted sit-up testing. Now, I'm going to take you through these 4 tests in just a minute, and we're going to go through brief demonstrations of these. Understand that these are listed in order of least vigorous to most vigorous. So particularly for your patients that might be more severe and more irritable, you definitely want to start with the first one and work your way up. Okay? As soon as you hit one of these that is positive, and we'll talk about what constitutes a positive test in just a few minutes, you're done. You don't need to do any more vigorous testing than that. But generally speaking, these tests are really good at differentiating a hip joint pathology from an abdominal pelvic pathology. And if you know you've got an abdominal pelvic pathology and you've ruled out a true hernia and you've ruled out some of those other tendons, you can be fairly sure that what you're dealing with is this condition. So without wasting any more time, let's get into these tests right now. So the 4 tests we're about to cover, these are all tests that can be used in the assessment of abdominal pelvic pathology to differentiate it from a potential hip pathology. And these are all 4 that you can use in the assessment of athletic pubalgia. Now I'm going to start with the least vigorous test, and we're going to gradually work up in vigor. We don't want to start with the most intense one, because if the patient has a high severity or irritability, well, that's just going to be mean. So the first one is just a sit-up. Now, it doesn't need to be a full sit-up. I usually have the patient do the sit-up to about 30 or 45 degrees, at least enough to clear their shoulder blades off of the table. So what I will do to help them, I will initially hold the legs down with the knees straight like this. So go ahead, cross your arms for me. And I want you to do a sit-up just to about 30 or 45 degrees off of the table. That's good there. And then come back down. And what we're doing is we're assessing for a reproduction of familiar pain in and around the groin or the hip area. If that reproduced that familiar pain, we're done. And we can pretty much conclude that it's not a hip pathology because there's no reason that a sit-up would produce hip pain. It's going to be an abdominal pelvic pathology. Now, if that did not reproduce pain, we're going to take it a step further. So I'm going to bring the legs together a little bit just so it's easier for me to hold down. I want you to keep your arms crossed, do the same sit-up. So come up. And then I'm just going to add a tiny bit of resistance. Not a huge amount. This is not a max manual muscle test. And then have her come down. Again, if that reproduced her familiar pain, we're done. But if it did not, we're going to move on to the next one. So for the next one, I'm going to have her bend her knees up, both of them, to about 90 degrees like this. What I'm going to do here, we're going to spread the legs just a little bit. So I'm going to try to push her legs outward. She's going to use her adductors or inner thighs to push her legs in. We're going to balance each other. Again, it's not maximal. It's just enough to elicit the activity of the adductors. So go ahead, cross your arms for me. So I'm going to try to push these out. Don't let me. Keep those inner thigh muscles engaged. Hold that. And while you hold that, do the same sit up to about 30 to 45 degrees while you push these in. Hold that. And then come back down. Because of the common attachment of the core muscles, particularly rectus abdominis and the adductors, adductor longus and pectineus on the pubic aponeurotic complex, the addition of that adduction, that makes this a more aggressive test than either of the previous two. And if that one does still not elicit the same pain, we're going to do the last test. So for this one, unlike the others, is a unilateral test. You're going to stand on the affected side. So this would be the case if she were to have right groin pain. And of course, we would also want to test the unaffected side. I'm going to cross this leg over as if we were doing a Faber test. And what I'm going to do is I'm going to, in just a minute, gently push down here, have her resist. So that'll be right adduction. And I'm going to put my hand on her contralateral or left shoulder. And she's going to, as if to do a sit-up where she brings her left shoulder towards her right knee. I'm not actually going to let her come up, but it's still going to elicit the same muscles. So can I have you cross your arms again? I'm going to try to push down here. Don't let me. And now I want you to try to bring your left shoulder to your right knee. And good. And relax. And that is the last of these tests. And again, if that elicited her familiar groin pain, then that would be a positive test. And we can conclude that she has an abdominal or pelvic pathology and not a hip pathology. Now, as I said earlier, these tests are generally good for differentiating a hip pathology from an abdominal or pelvic pathology. So they have fairly good sensitivity, so they're good screening tools. In other words, if you do these tests and they're all negative, they don't reproduce the patient's pain, you can be pretty certain that they do not have an abdominal or pelvic pathology. So that essentially rules out a condition like athletic pubalgia. But they all have very poor specificity. So if the test comes back positive, it cannot be used as a standalone test to determine that the person has a sports hernia, aka athletic pubalgia. But if you combine that positive result with the results of the rest of your examination, you can add those things together, so to speak, and be fairly confident that what you're dealing with is a sports hernia. And a positive test, as I mentioned in those videos, would be reproduction of the patient's familiar groin pain. Now at this point, we know what we're dealing with. We know this is athletic pubalgia, aka a sports hernia. What do we do about it in the clinic? Well, our general approach is going to be to strengthen the core. Remember, we've got a weakened abdominal wall or potentially a small tear in it, not to the extent that organs are protruding through it, but it is weak and we need to strengthen things up there. Also understand that I'm beginning here with core stability, but not every patient needs to start with that. This is most appropriate to start with when you've got your highly severe or highly irritable patients. If they're lower severity, low irritability, they may be able to enter into a dynamic core strengthening initially. But you might always verify that they're able to tolerate that first, and if they cannot, regress back to core stability. And generally speaking, we want to strengthen the core in all three major planes. So here's some examples of exercises. In the transverse plane, we might be executing the Palpation press. We might be doing bird dog rows or a plank with lateral dumbbell drag. In the coronal or frontal plane, we might be doing a suitcase or farmer's carry, asymmetric sit-to-stand / squats, a suitcase deadlift, something like that. In the sagittal plane, we could do bilateral active double-kneaded chests, some supine pullovers or some dead bugs, some things where we're not actually allowing any lumbar movement. So these would be regressed exercises compared to their dynamic counterparts in the same planes of motion. But once the person is easily able to tolerate core stability exercises, I try to progress them to dynamic core exercises in those three major planes as quickly as possible. So in the transverse plane, maybe we've got banded or cable lumbar rotations. If they become fairly advanced, you can do GHD rotational sit-ups, but understand those are actually quite difficult. And I would definitely not start with those for the vast majority of people, especially with an injury like this. In the coronal plane, we've got our Roman chair side bends. We've got standing weighted side bends. We've got hip dips. Out of those three, the standing weighted side bends are going to be the most regressible in terms of load. So that's probably the one I would start with. And once they become fairly tolerant to high weights on that, we might experiment with the Roman chair and maybe even try some hip dips. In the sagittal plane, we've got reverse sit-ups. We've got gar hammer raises, which are essentially reverse sit-ups just on a decline, and then GHD sit-ups. And we can just progress those as needed over time to strengthen up the core. Now, I don't want you to think of these next two things as occurring after the dynamic core strengthening. I might start the dynamic core strengthening first, but while we're progressively overloading those, I might add in some of these things as we need. So these overhead variations of other core strengthening exercises and specific return to sport, return to work based exercises, these can be occurring at the same time that we're working on the dynamic core strengthening, okay? Even though I put them last in the list. Ultimately, our goal is to get the person back to work, if it's maybe workers' comp or something like that, or get them back to the sport that they got injured with in the first place. So that's for the core. Now remember, we also have the adductors, and it doesn't mean there's an adductor strain. It just means that some of those adductor tendons originate on the pelvis in the area where this tear occurred. And so sometimes you can have adduction, particularly resisted adduction, be very aggravating to a sports hernia. And so if we're going at this from an adduction perspective, we might be doing these alongside the core exercises. These are not in isolation. These can be together if we need these to be. And so for the adductors, I would probably, again, for your high severity, high irritability patient, start with isometrics. You've got isometric ball squeezes, and those are in the sitting position, so the knees would be bent. We've also got isometric straight leg abduction, and the difference between those two would be with the straight leg, you get a lot more gracilis, and when the knee's bent, you don't get as much gracilis. You get a lot more of the other adductors, okay? You can progress to a bridge with a ball squeeze, and then eventually a hip thrust with a ball squeeze. The one commonality between all of those is the adductors, for the most part, are functioning isometrically, okay? And again, once isometrics are very well tolerated, fairly easy, I try to progress to dynamics as quickly as possible. Now, one of the most versatile adduction exercises that's dynamic is the adductor machine that you have in a lot of gyms. Not every clinic is going to have this, and not every person is going to have access to a gym that has this. So I have another video where I explain how to set up a home version of this with a band. This is actually something I use a lot with patients because my clinic does not have an adductor machine either, but it's very useful and you can use it very similarly. Adduction machine is very good here, okay? But remember, we've also got modified Copenhagen's and eventually full Copenhagen's. Again, modified, the knee is bent. You've shortened the lever arm, it's going to be an easier movement. Full Copenhagen's, the knee is straight. It's a longer lever arm depending on how you do it. It's going to be a harder exercise. Now, the disadvantage of the modified and full Copenhagen's is you have to have a pretty good amount of core stability and a pretty good amount of adductor strength to begin doing those. Not everybody, when they start dynamics, is going to be able to go directly to a modified Copenhagen. They may need to do some adduction strengthening prior to that, and by no means is the adductor machine the only way to do that. There's many exercises you can accomplish that with, and we talk about that in the adduction strengthening video on my channel. And hopefully after watching this video, you have a better understanding of what athletic pubalgia, or sports hernia, is, how to diagnose it accurately, and then what the general treatment approach is for this condition. Please make sure to like this video, subscribe to my channel, and hit that notification button for notifications for all videos in the future. Thank you so much.